Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of Rasmussen's encephalitis. So this is a case of a 33-year-old male patient who presented with recurrent seizures, for which he underwent a craniotomy to obtain a biopsy because the radiological appearance on the MRI was once suggestive of perhaps a diffuse infiltrative process, and on review, it was suggestive actually of encephalitis. So they decided to go on and to obtain a biopsy. And this is actually a generous biopsy from the temporal lobe. And as you can see here, this is the cortex. There is some distortion of the cortex here, some perivascular inflammatory infiltrate here, and some pink, really a toleration for the white matter, for which I'm going to zoom in first on the area here. And as you can see on higher power magnification, there is complete destruction or disruption of the cortical architecture with loss of neurons, but it is still very busy. On higher power magnification, there are no neurons, some inflammatory cells perhaps here, some normal vessels that are present in the cortex, but barely any neurons present. At one focus, at the edge of the area in which we have some busy cellular component, there were some scattered normal appearing, and this is extremely important, normal appearing ganglion cells. Now, this is the white matter just beneath the cortical area, and as you can see here, we started to see gymestiocytes, but these are reactive gymestiocytes. This is a gliosis that is occurring in the white matter, and this is another focus where we have really abundance of the gymestiocytes present. Of course, remember that in the temporal lobe in particular, we can encounter some normal neurons slightly deep in the white matter. This is an absolutely normal occurrence. This should not be promote us to diagnose the case as ganglioglioma, for example. And again here, more of those gymestiocytes. But what I would like to draw your attention to is those rod cells. These are the microglial cells that are known as rod cells, and I'm going to show you more. And this is also indicative of a reactive process. And on another focus, these are all the cells with the elongated nuclei that we see here scattered. These are all rod cells or the microglia or the macrophages of the central nervous system. And more here, really distortion of the architecture, but this is not neoplastic. This is completely inflammatory / reactive process. And this is a very nice example of rod cell, one here, and one here. And again, more of the same appearance, but here with the predominance of the rod cells. I really wanted to highlight the rod cells because we always read about the rod cells, but we rarely see them as clear as is in this case. Now, in this particular case, some of those rod cells aggregated around what appeared to be a degenerated neuron. Importantly, there was evidence of perivascular inflammatory infiltrate, mostly composed or solely actually composed of lymphocytes. And again, we can see the reactive gymestiocytes in the background with abundant acidophilic cytoplasm. Now, some of the vessels contain perivascular hemosiderin-laden macrophages, and these are because of some microhemorrhages that occur as a consequence of seizure. Remember, the patient has frequent seizures, chronic seizures lasting for more than 6 months, and because of the movement of the head, microhemorrhages occur, and a result, hemosiderin-laden macrophages would aggregate around the blood vessels. Now, importantly, into immunohistochemistry, CD20 barely showed some CD20 positive cells, and this is on higher power magnification around the vessels. But what was really important is that the vast majority of lymphocytes around the vessels were CD3 positive, and the CD68 would really highlight the cytoplasm of the rod cells. This is one nice example. All of these are activated microglial cells that are present around the blood vessel, but also within the substance in the areas that I just shared with you. And as you can see here, this is the cytoplasm of the rod cells, and the rod cells are really activated. We do not usually see this amount of rod cells when we apply CD68 to a normal brain. Chromogranin A is positive in the neurons. Now, if this was outside the context of the temporal lobe, we would have been tempted perhaps to call this or to consider at least ganglioglioma. But remember, in the temporal lobe, ganglion cells or neurons are normal in the white matter, and they can stain with the chromogranin. This is normal. This is not considered to be abnormal or indicative of ganglioglioma. Only in the temporal lobe, not otherwise, not in the frontal, parietal, occipital, or other areas. CD34 was completely negative, and in a way, this would support that whatever neurons are present are not dysplastic, but this is not an absolute criteria. P53 showed this mosaic pattern of staining non-mutant, and Ki67 was barely positive in some of the inflammatory cells, not in the reactive gemestiocytes. So the final diagnosis in this case, in consideration of the clinical history as well as in correlation with the radiological finding, that this is an inflammatory process, not a neoplastic process, and would be consistent with Rasmussen's encephalitis. Remember that Rasmussen's encephalitis occurs primarily in children who present with the chronic seizures, but yet can be seen in adolescents and adults, as in this case, which makes the consideration for the diagnosis more difficult. Remember that this is completely inflammatory process in which the rod cells, which are activated microglial cells, become very prominent with CD68 positivity highlighting them. CD3 positive lymphocytes outnumber the CD20 lymphocytes around the blood vessels. This is extremely important, and we also encounter some gliosis because of loss of ganglion cells in some areas where really the focus would be mostly, at least in this biopsy, in the temporal lobe, but usually Rasmussen's would really affect almost one hemisphere. So it's considered to be like hemispheric involvement. Previously, it used to be treated with hemispherectomy, but nowadays, of course, we have medications that would control the seizure. Some patients would benefit from steroids, long-term steroids. I hope you find this tip useful in your daily practice. Thank you.